Hello everyone, good evening and good afternoon to you, sir. Myself, Sharon, I am the Vice Chairperson of NPS's Sahrdaya. First of all, I would like to welcome you all for our event. Let me give a very brief introduction about our society. NPS Society, the IEEE Nuclear and Plasma Science Society is a professional group on nuclear science within the IRT. It is a technical society that covers the field of nuclear and nuclear medicine and imaging science, plasma science, etc. Our society organizes and supports many conference workshops each year. So now I would like to welcome each one of you to this event. So first of all, let me give a brief introduction about our speaker, Dr. Martin Grossman. He's an IEEE senior member and currently chair of 2 NPS committees, CANPS and TNC. Also, he's a very prominent speaker and quite famous for his distinguished lectures. And we are indeed so happy to get you as a speaker for the day. So welcoming you, sir. Okay. And over to you. Let's start that.
Okay, thank you very much, Sharon. Hello to everyone who is listening here to this lecture. It's really a pleasure for me today to talk to you and share with you a little bit about the work I've been involved in over the past years. I have started as a career in high energy physics, but about 20 years ago I drifted to a field where the technology that is used in high energy physics is applied for a very concrete purpose, and that is for the treatment of cancer patients. And this is the topic that I will talk about today, proton therapy, and we are doing this here in the laboratory where I am working. We have been involved in developing the technology, and in the meantime, nowadays, there are about 100 centers in the world where this kind of treatment can be offered. So I will give you a lot of details about the proton therapy. I would like to start, however, with a short introduction of my laboratory. We are located in the center of Europe, in Switzerland. You see this here on the map, not far from the biggest city in Switzerland, which is Zurich. But we are on the countryside. This is an aerial view of our laboratory, about 2,000 people working here. And the main thing is that we have a few large installations. We have in this building here a 590 MeV cyclotron for protons with a very high intensity, 2 milliamperes. That's the world record for a proton cyclotron. We have a smaller cyclotron that is used for what I'm talking about today, the proton therapy. We have a synchrotron light source, an accelerator for electrons, which are then used to produce X-rays of a very good quality. That's used for many different purposes, but the focus here is on material science and on biological research. And in the forest, you see when this picture was taken, there was some construction going on. In the meantime, we have finished here a 700-meter long linear accelerator also for electrons, which is a free electron laser. It's similar to what you can do with a synchrotron light source, but it has a time structure. So like a stroboscope, it allows you to take a time resolution of processes that happen on a very short time scale, like chemical reactions, for example. And we already heard from Sharon about the Nuclear and Plasma Science Society as part of IEEE. I'm giving this lecture here as part of the Distinguished Lecture Program, which supports sending people like me. There is a large group of people that volunteer to give these lectures for IEEE to chapters and student branches all over the world. And in normal times, we can travel and meet you in person, and we would very much love to do that. But as you know, at the moment, this is not possible. In this case, IEEE would sponsor the travel. So we hope very much that the world will turn a little bit back to normal, so that maybe next year or maybe in 2 years, it will be possible again to travel freely. And if you like my lecture today, I'm more than happy to come and visit you in Kodakara sometime in the near future. So let's start with the topic of today, which is radiotherapy with protons. Radiotherapy uses the fact that radiation is dangerous for biological tissue. If you have a cell that gets dosed, then this cell is inhibited in its way to reproduce, and ultimately it will die. And this is what you use in radiotherapy. Normally, radiotherapy is done with high-energy X-rays. In many hospitals, it's one of the routine treatment modalities for cancer. And we propose to do radiotherapy with protons. Now, why do we do this with protons? You see two pictures here. On the left side, this is a conventional therapy device for photon therapy, X-ray therapy. And then on the same scale on the right, this is a typical proton machine. You see a person standing here. So these machines are so much bigger, they are more heavy, they require more space, they are more expensive, obviously. So why do we treat patients with protons? Well, the difficulty in radiotherapy is not so much to cause damage to the cancer cells. For this, you just irradiate long enough onto a cell, and ultimately it will reach enough dose and it will for sure die. But the difficulty is much more to spare the healthy tissue, the tissue that is surrounding the tumor, the tissue that is in the flight path of the radiation when it's a tumor that is deeper seated in the body. And for this, protons have an advantage over X-rays. And the advantage is, of course, due to the physics of protons. And this is what I'm showing you here in this graph. You have on the x-axis the penetration depth of the radiation into the biological tissue, 10, 20, 30 centimeters. And on the scale here, you have the effect of the radiation, the dose. Protons have this behavior. They penetrate in the tissue, cause a little bit of damage, and then in a certain depth, there comes a position where the proton beam stops. And where it stops, it's where it causes the biggest damage. And because it stops here, there is no effect downstream of this point. If now you have a tumor that has a certain extension in proton range, like here, 15 to 25 centimeters, you can change the position where the protons stop by modifying the energy. If you reduce the proton energy, the protons will stop a little bit sooner in the tumor. So in the sum, you get the blue curve, which covers very well the full target region. You have a little bit of damage here, and no dose is deposited downstream of the tumor. And now this you should compare with what you can do with conventional photon therapy. The curve for photons looks completely different. It's an exponential curve. You get the biggest effect close to the surface of the body. Then the dose decreases. In the target region, you have something similar like you have with protons, but you also get dose downstream of the tumor. So what you need to compare are these surfaces. This is the dose that you do not want in case of photons. And in the case of protons, this dose is not zero, but as you see, it is much less. So protons are just more precise than photons. You can limit the damage really to the target region. This is not necessary in all cases. Sometimes you don't require this precision. But if you have tumors, for example, that are in the brain, close to some critical structures in the brain, then these are cases where the bigger effort, the bigger machines for the protons are justified. I have here a little bit of more clinical example. In black and white, you see 2 times the same picture. It's a CT image of a patient that has a tumor in the neck here. And the colors show the dose that is deposited on the left side if you use photons, on the right side if you use protons. So red meaning 100% of the dose, and then gradually going down. The hotter the color is, the more dose you deposit. The tumor is seen here, this orange outline. It's in both cases the same. And you see that with photons, you can cover the tumor with the necessary dose, but you get dose all over the rest of the neck, in this case, where you don't want the dose. And with protons, you can cover the tumor, but you can limit the dose much better to the proper target region. What are the main parts of a proton treatment facility? First of all, you need an accelerator, which is the source of the charged particles, in our case, the protons. There are different types of accelerators. On this picture here, you see a cyclotron, which is the most commonly used accelerator type, but it's also possible to use synchrotrons to produce therapeutic particle beams. Both accelerators have their advantages and their disadvantages, so it's a choice which you choose. Then you need beam transfer lines to bring the particle beam into the treatment rooms. One accelerator can furnish the proton beam for a couple of treatment rooms, maybe 4 or 5 treatment rooms. And then you have basically 2 different types of treatment rooms. One, which we call fixed beamline treatment rooms, where you have just the beam coming out of the vacuum beam pipe, and the patient is placed on a fixed chair in this case, or it can be a fixed bed. And the other type of treatment rooms are these kind of machines, where the last part of the beamline is built so that it can rotate around the patient. For this, we use the word gantry as a part of a machine that can rotate around the patient. And this has then the advantage when you combine different incident angles, you get the concentration of the dose in the crossing point of the proton beam. This is one example for a cyclotron that can deliver proton beams. This is the cyclotron that we are using at my institute. We didn't build it ourselves. We bought it from a company which is now belonging to Varian. And it's a rather compact cyclotron. This is about 3 meters in diameter. It is superconducting. This allows it to make it small, and it is very service friendly, which is important because when you have a clinical program going on and you want to have a machine that is really reliable, not to cause any delays and waiting times for our patients. This is a photo of our cyclotron. You see here the accelerating structures where alternating high voltage with a very high frequency is applied. The proton source is really in the center, and then the protons get faster and faster and faster, and then when they reach the maximum speed, we extract them out of the cyclotron. And you can see here that we can cover the cyclotron from the top and also from the bottom, and it's relatively easy to open the machine, so if there is the need for some repair, you have easy access to the center of the cyclotron. This is what our facility looks like. I've shown you the cyclotron, and in our case, we have 1, 2, 3, 4 different treatment rooms, 3 of them gantries, and 1 is a fixed beamline. These 3 treatment rooms have been built by us, and I will explain you the details of these treatment rooms in the next slides. This gantry here is a commercial gantry which we bought from a company, Varian, and then integrated into our treatment facility. So now I should talk about irradiation techniques. How do you manage to get a dose distribution that really covers the form of the tumor. The classical way to do that is shown in this picture. You take the proton beam. When it comes from the accelerator, it's about the diameter of a finger, 1 centimeter for the maximum. And then you let it pass through a scattering foil. That's a thin foil of metal or carbon or some material. It doesn't really matter so much. The effect of the scattering foil is that you broaden the beam. So the beam gets wider, and then you bring in the beamline a collimator that has the form of the tumor cut out. So you shape the beam in 2 dimensions. And then you position the patient downstream of this collimator. Of course, this collimator is patient-specific. You have to make it individual for each patient according to the form of the tumor. But once you have produced such a collimator, and once you have positioned the patient correctly, it's a relatively simple irradiation technique. The only quantity you control is the dose. You switch the beam on and you switch it off in the right moment. So this technique was used since the 1960s to start using proton beams for particle therapy. And in my institute, we have started in the 1980s with a specific program to treat tumors in the eye. You see the photo here. This is the view through the pupil of an eye of one of our patients. You see the background of the eye, and this here is a tumor that is growing into the eye. And these tumors are melanoma. It's a form of skin cancer, and they are dangerous. They destroy the eye, that's one thing, but they also easily build metastasis in other organs of the body. And this, if not treated, can be fatal for the patient. So when you discover such a tumor, you have to remove it. And before there were protons, there was only one way to remove the tumor. You have to remove the eye. Most people have 2 eyes, but if you can conserve an eye that has this kind of tumor, it's of course a big win for the patient. And so this kind of tumors were sort of a pioneer field for the treatment, for using the protons as a treatment. To treat the patients, we prepare them by surgery, which is shown here on the upper left picture. This is the ophthalmologist. Takes the eye under anesthesia, pulls it out a little bit of the socket, and shines with a lamp through the eye. And melanoma are dark, have the dark color, so you can see the shadow of the tumor on the eyeball. And the position is then marked by stitching very thin metal clips on the position of the tumor. A couple of days later, the patients come to my laboratory, the PSI. We prepare such a mask, which is adapted to the form of the head of the patient. The patient has a bite block in the mouth, and so you can't really move the head anymore. And the patient is sitting on a chair, which is held by an industry robot, an hexapod robot. And then the patient is brought in front of the beamline. You see here, this is the last end of the vacuum pipe where the proton beam is transported from the accelerator to this point, and then from here on, the protons travel through air. A short distance of a few meters is no problem for protons to travel through air. You see here the scattering foils. You see measurement devices that check the dose, that also check the position of the beam. And when we look a little bit closer here, you see the patient has been turned in the direction of the beamline. And at this position, we put these collimators. And on the upper right, you see 2 examples of such collimators. They are produced by our mechanical workshop based on the diagnostic information that we have for the patient. And now we don't yet switch on the proton beam. We take an X-ray. And the tumor is transparent for the X-ray. You cannot see it on the image. But what you can see are these metal clips that have been put onto the eye in the surgery. And that's the reason why we do this surgery. You see this photo here on the lower right. You have the nominal position in color, in this magenta color, and you see the shadow of these metal clips. So on this picture, the patient is a few millimeters too low. We send a position correction command to the robot that is connected to the chair. The patient is lifted up a short distance. We take a second X-ray until we are satisfied with the position. And then the irradiation, proper irradiation happens. We do this in 4 sessions of 1 minute each. And after 4 sessions, the patients can go home. The 4 sessions happen on 4 consecutive days. And so after a week, the patients can go home. And the results that we obtain are really very good. Since 1984, we have treated more than 7,500 patients. And in 98% of the cases, we are able to cure the patient. It's a really very, very good number. Cure here means 5-year local tumor control. The tumor does not grow, no danger for metastasis. And very important, in most cases, we can conserve the vision. The patients can see as well as before. So for small tumors, always, and for big tumors in 90% of the cases. So these are really very, very good numbers. And this has led to the fact that protons are really the standard treatment for these kind of tumors. Motivated by this success, we have started in the 1990s a second program for using protons for cancer treatment, aimed at larger tumors, deeper seated in the body. But the most important thing is we use a completely different irradiation technique. And this is what I'm explaining you in this next slide. You take again the proton beam from the accelerator, but now you leave it thin as it comes out of the accelerator. And you use the fact that with a magnet, you can change the direction. You can change the direction of the proton beam. So you set the magnet at a specific value, and then you switch on the beam for a short moment. So you deposit a dose point here. Then you switch off the beam, change the magnet a little bit, and you see what's going on. You produce one line in the patient with those spots that are covering one line inside the patient. And now something happens here in front of the magnet. You put in some material, and the effect of this material is that the protons lose a little bit of their energy, and then you repeat the scanning process. So the protons will stop a little bit sooner in the patient. And now it's clear how the story continues. You put even more material in there. You eventually adapt the range of the magnetic scanning. So this technique allows you to cover an arbitrary 3-dimensional volume inside the patient without the need for patient-specific hardware. You don't need these collimators that have to be produced for each patient individually. This is all controlled electronically and by computers. So the idea to do this is already very old, but it took until the 1990s that the technology was available to really apply this technique. You need fast electronics, you need computer control, you also need the proper imaging methods. You need computer tomography, you need eventually MRI imaging of the target region in order to prepare a patient for this kind of treatments. So we built in the early 90s this machine here, our Gantry 1, which is the first implementation of this technique. You've called it spot scanning. Nowadays, the term that is mostly used is pencil beam scanning, PBS. This machine is really a beamline that can rotate around the patient. You have here the vacuum pipe, and then everything that is on this green gantry can rotate. We rotate the beam first out of the axis, then bend it so that it is parallel to the original axis. Here we have the scanning magnet that can change the beam direction, and then have a big 90-degree bend where the beam then goes onto the patient. This big 90-degree magnet is under this cover here, and here in what we call the nozzle of the gantry, we have this system that brings the material into the beamline pneumatically to change the energy of the proton beam. And we have measurement devices that check the dose, that check the beam position. And with this machine, in 1996, we treated the first patient. And for 12 years, we were the only spot scanning machine in the world. And then I want to show you here a little bit the development of the spot scanning over the past years. You have I forgot to put the the explanation here. Blue means gantries that use this classical scattering technique, and red means gantries that use this magnetic scanning technique. So there was one center where they had 3 gantries, but they were using scattering from 1990 to 96. Then here it's our gantry 1, and we stayed for a long time the only place. And then there became more scanning machines available, and around this time commercial scanning machines became available. If you have the money, you can buy it from a company. There is a handful of companies nowadays that can produce such scanning machines. And so you see already 2015, scanning became more important than the scattering, and the scanning technique is today really the standard when you want to install a new proton therapy center, you want the scanning technique. So that's something we invented 25 years ago, and we're still a little bit proud about it. After a few years operation of Gantry 1, we thought, what would we improve, what would we make different? And this led to the development of our second generation Gantry 2, that you see on the upper right picture. And we have a number of improvements in this machine. Some have to do with the patient workflow, with the accessibility to the patient during the treatment. If there's some problem, how quickly can you get to the patient? But the technological improvements, they have to do here with the speed. How fast can we apply the dose to the patient? And Gantry 1, as it was the first machine to do the scanning, had only 1 magnet to change the beam direction. And we did the second direction by moving the patient table. But moving a magnet is much faster than moving a table with a patient on it, a mechanical motion. Moving a magnet is milliseconds, and moving a patient table is a fraction of a second. So Gantry 2 has 2 scanning magnets, so that we don't need to move the table, but we can scan in X and in Y the form of the tumor. And the speed is not only important to shorten the treatment time for the patient. Typically, it's a few minutes treatment time. It's not so much. You don't invest in the speed to reduce a few minutes to a few seconds. But having a fast scanning system is essential if you want to treat tumors that are moving due to organ motion. For example, if the patient breathes, a tumor can move a few centimeters, and then you lose the advantage of the precision of the protons. But if you are fast enough, you are still able to treat this patient with tumors. And so, again, here, expanding the technology allows you to expand the indications, the kind of tumors that you can treat with protons. A few impressions on the construction of this Gantry 2. This was in 2006. We had the delivery of the mechanical structure. Here is the mounting of the biggest magnet, the 90-degree magnet. You see this here is the vacuum chamber. The beam is coming here from the accelerator and then is bent by the magnet and is coming here towards the patient. This magnet are 2 parts which are mounted here together. And here, the magnet is ready. You see the proton beam coming on here. This is already the patient table. We put a measurement device during the commissioning of our machine. Then we made the room look a little bit nicer for the patient to feel more comfortable and not like in a physics laboratory. We added a CT here for the imaging of the patient. And in 2013, we were able to treat the first patient with the second generation Gantry 2. One target for proton therapy is the treatment of small children. In a child, it is even more important than in an adult to give dose only to the target region, only to the tumor, and spare the rest of the growing organism. So about 1/3 of the patients that we treat are small children. And now it's important that during the treatment with protons, the patients do not move. And for a small child, this is not possible, so they have to be treated in anesthesia, which is an additional logistical complication. We are working here together with the anesthesia team from the Children's Hospital in Zurich. They come to PSI, they start the anesthesia, the parents of the child patient can be present. When the child is sleeping, it's positioned on the treatment bed, brought into the treatment room. You see the child here lying on the back. The position of the head in this case is fixed with a bite block that is inside the mouth of the patient, and so the head is well fixed. And during the irradiation with protons, nobody except the patient can be inside the treatment room. So the anesthesiologists, they have to go outside of the treatment room and rely completely on the measurement devices that supervise here the vital signs of the patient. So they are outside, they see video monitors, they have here the anesthesia monitors. If necessary, they can, if there's a problem with the patient, they can quickly go inside, they can open the door. This will cause an emergency shut off of the cyclotron so that they, within 1 minute, they can be inside the treatment room. But this was a very unusual situation because in the surgery room, the anesthesiologists are used to stand right next to the patient to be able to intervene if there's some problem. But we are doing this now since many, many years. We have treated about 700 children without any accident. So this is, now we are very confident, and the anesthesiologists are very confident in this kind of treatment. After the treatment, the child is brought to a recovery room where again the parents are present when the child wakes up. I want to talk a little bit about the technological side of proton therapy and the improvements that we do in the scanning technology. This year, one spot after the next. This is a little bit what I explained in this little cartoon a few slides ago. And you can do this in 2 dimensions. So this is like a step and shoot method to paint the form of the tumor. But you could also think about another way to scan the proton beam. You do the scanning and you do not switch off the beam. You do this continuously by painting lines. And this is what Gantry 2 can do. And this means you will be even faster than in this step and shoot method. And you see that here we want a little bit more dose than what we want in this region. So for this, we have the possibility to quickly modulate the intensity of the proton beam. And how do we do this? If we look again at the cyclotron, and in the very center of the cyclotron, you see this small pipe here. This is where the ionized hydrogen gas is inside, and we extract the protons by applying a high negative voltage here. And the protons start doing their turn in the center of the cyclotron, and here we have a device which we call the deflector plate, and there we can apply, again, positive high voltage. So if we apply a positive high voltage, the protons positively charged, they come here and then they will stop, they will not continue. If we reduce this high voltage, the more and more protons will be able to continue here and get accelerated. So this is shown here, the high voltage applied to this deflector plate, and this is the current measured at the exit of the cyclotron. So with 0 voltage, you have the full current, and this applying the voltage here allows you to modulate the intensity of the current. And the advantage is high voltage is something which you can control very, very quickly. And so this allows us, while we, in this image here, while we move continuously with the scanning, we can change at the same time the intensity, and this gives us a lot of flexibility in the application, a lot of flexibility and a lot of speed in the application of the dose. The key here is you need really state-of-the-art electronics to do that. The system that we use to control all these devices uses a lot these FPGA chips. These are programmable chips which allow you really in firmware to control the high voltage power supply, the power supplies of the magnet that control the scanning. And all these applications are only possible because we have this kind of technology that has been invented for high energy physics available to us. Yeah, so we do some painting here. You see we move the proton beam along a line, we switch it off completely, then we switch it on again at a reduced rate. So we are really controlling this according to what we wanted in our specifications. I have already mentioned the treatment of moving targets is one of the challenges in proton radiotherapy. You see I have a tumor here. It will move when the patient breathes. And the image here shows a simulation of the dose that you apply to the tumor. In the static case, patient does not breathe, you get a nice homogeneous dose distribution. But when you have motion, you get a lot of inhomogeneity in the dose. And this is something you do not want. You don't want hotspots like this one. You don't want regions that don't receive the target dose. And so one way to cope with this problem is to do rescanning. You apply, say, 10% of the dose and then repeat it 10 times. And this here is not a simulation, it's a measurement. We have built what we call a phantom. It's a detector which looks a little bit anatomic and which has anatomically similar material inside. It can breathe by using here an air pump, and inside this artificial chest we have placed a measurement device, this what is supposed to be the tumor. And now you look at these images here on the lower part of the picture again. The static case is like this, quite homogeneous. When you switch on the motion, you get a lot of inhomogeneities. And then you do this rescanning, give several passes by applying the dose. And if you do this often enough, you see this here 8 times, you get homogeneity which is comparable to the static case. Repeating this 8 times, 10 times, 20 times requires that the dead time is very slow. If not, you would extend the treatment time for the patient from 5 minutes to 1 hour, and this is already prohibitively long. So again here, speed, fast magnets, fast power supplies, fast readout is essential to be able to treat this kind of tumors. So I have talked a lot about the machines that we have built here, and I would very much love to show you our center. And for this, I have produced a short video which shows the treatment room and which also shows the accelerator. And I propose I take a little break now and show you this video. Let me bring this up. And I see there is a problem with the video, with the audio, I'm sorry. So let's stop this here for a moment. I will stop the screen sharing and start again with the option for audio sharing. Hello and welcome to the Paul Scherrer Institute here at the Center for Proton Therapy. My name is Martin Grossman. I'm working as a physicist here for more than 25 years in the Center for Proton Therapy. At our center, we treat each year more than 500 patients with radiotherapy. Conventional radiotherapy that is applied in many hospitals uses X-rays to treat cancer. In contrast, we don't use X-rays here, we use proton beams. Now, proton beams require bigger and more complicated machines, but they have an advantage. The precision is better than in the conventional radiotherapy. This precision is not required for all kinds of tumors, but for those cases where such precision is important, protons have a clear advantage. So please follow me on a tour of our center. On this picture, we have an overview of our facility. To give you the scale, this is approximately 50 meters of distance. In one corner of this building, we have the source of the proton beams. This is our accelerator, where we bring protons to a high speed that can be used to treat patients. The proton beam can be directed with magnets into different treatment rooms, like a light beam can be directed with mirrors and lenses. And we have 4 different treatment rooms. This room here is the Gantry 1 treatment room. It's a PSI development, and actually this machine was the first in the world to implement the magnetic pencil beam scanning to adapt the dose distribution to the form of the tumor. It has been in clinical operation since 1996 until 2018, and nowadays it is still in use, but only for biological experiments. A few years after Gantry 1, we have built a second Gantry 2, which is the PSI development based on our experience with the first treatment Gantry. It has a lot of improvements. Some improvements concern the patient workflow and the accessibility of the patient during the treatment, but there are also a number of technical improvements. We have a smaller beam size, so this gives an even better precision of the proton treatment. We have a faster scanning, and this gain in speed allows us to treat more indications than we can do on the first Gantry. The keyword here is organ motion. It's possible to compensate organ motion of tumors in the lung, for example, that cannot be treated on Gantry 1. Gantry 2 is in clinical operation since 2013, and we are treating these moving targets on Gantry 2. We have a third gantry, Gantry 3, which is the result of a research collaboration between PSI and an industrial vendor, Varian. It combines the technology of Varian with PSI's own technological developments. For example, we have implemented here fast energy changes, which is PSI technology, and this enables the treatment of moving targets also on Gantry 3. A fourth treatment room is a bit simpler, and it is dedicated to the treatments of eye tumors. On this facility, we have treated more than 7,000 patients with a very high success rate. This is the control room where during clinical operations, 2 radiation technologists oversee the correct application of the treatment. We have a lot of computer monitors, some here for the imaging systems. Then on this side, we have computer monitors for the therapy control system, for the safety system, and status display of the accelerator. And important, we have video coverage of the treatment room, so at any time we can see if the patient is okay. We can communicate with the patients via microphones and loudspeakers. Here we are in the treatment room Gantry 2, PSI's second generation gantry. The patient enters from outside. We position on the table a patient bed that is adapted to the form of the patient body. And then the next machine we use here is our computer tomograph, the CT. It has 2 functions. One is in the preparation of the treatment. We take a full scan of the target region, which is the basis for the plan, the therapy plan. And the second function is that every treatment day, we verify that the position of the patient on the couch is exactly as on the treatment day. When this positioning check has passed, we move the patient with the couch in the treatment position. This could be the start position for the treatment. The proton beam is coming in this orientation from the top onto the patient. During the treatment, there is none of our personnel in the treatment room. It's all controlled from a control room outside. The typical treatment time is a couple of minutes. The patient does not feel anything from the radiation. Also, there are no loud noises during the treatment in the treatment room. What we do most of the time is that we combine different incident angles to get a concentration of the dose in the crossing point. And for this, it is possible to rotate the gantry around the patient. Gantry 2 is in clinical operation since 2013. In parallel to the clinical operation, we continue to develop our scanning technology and take advantage of the technical potential of Gantry 2. And this is possible in a laboratory like PSI, that we can have at the same time clinical operation and do the technological development. This is something which is much more difficult in a hospital. What we see in the treatment room is only a small part of the gantry. So I would like to invite you to take a look behind this door. This is the connection of the proton beam from the accelerator to our gantry. The proton beam is produced about 30 meters behind you and is transported through vacuum pipes controlled
by magnets to here, the treatment room. We have at this point a small distance of 20 centimeters where the protons travel through air. We have installed measurement instruments to check the beam position and intensity. And from this point on, the proper gantry starts, which is a continuation of the beam line with a vacuum pipe with magnets, which is able to rotate around the patient as we have seen in the treatment room. Here we are on top of Gantry 2. We see the Gantry beamline, the large magnets, and the supporting structure that is directing the proton beam out of the original axis, on top, again parallel to the axis, and in the treatment room coming from above onto the patient. The advantage of proton therapy is the high precision. Now, in child patients, this precision is even more important than in adults. So about 1/3 of the patients that we treat at PSI are small children. In order to avoid the movement of our child patients, they have to be treated in anesthesia, which we do together with the anesthesia team of the Zurich Children's Hospital. The anesthesia is prepared here while the parents are still present. And once the child is asleep, we bring the child into the treatment room and treat it just like we treat the adult patients. At the end of the treatment, the child is brought back, and just in the room next to us, we have the recovery room where the children, again in the presence of their parents, can wake up. This is the hall where the accelerator, the beamlines, and the gantries are installed. We have over there Gantry 1, we have over here Gantry 2. We cannot see the treatment rooms from here because they are all covered under concrete slabs for radio protection. But what we can see here is the infrastructure that is required to run a proton therapy facility. And if we walk along here, we have cabinets here that house the power supplies of the magnets which are installed along the beam lines. We have control systems for the patient positioning. We have more magnet power supplies. The cabinets here contain control and safety electronics. The cyclotron is just behind this wall. So what we see here are the radio frequency generators that pump the energy into the proton beam in the accelerator. And the main controls of our proton cyclotron. When the cyclotron is in operation, it is not possible to go inside and visit it because of radiation protection reasons. But today is a maintenance day, and the cyclotron is switched off, so this is our chance to go inside and take a look at the cyclotron. So this is the cyclotron comet, the source of our proton beam. The protons get accelerated to a high speed inside this cylinder. We can see here the point where the proton beam exits the cyclotron and goes into the direction of the treatment room. And to give you a little bit more explanation about the cyclotron, let's climb upstairs. The protons start their journey in the center of the cyclotron. Rapidly changing electrical fields make the protons go faster and faster. Under the big blue ring that we see here is a strong magnet that forces the protons on circular tracks. This magnet is a superconducting magnet. It's an electromagnet. There's a coil which floats in liquid helium at a temperature of -270°C. And we can see here the cryostat where we feed the liquid helium into the cyclotron. As the protons get faster and faster, the circular tracks become wider and wider, and eventually the protons reach the edge of the cyclotron, and this is where we extract the proton beam and send it here into the beam line toward the treatment rooms. Right here, a few meters outside of the cyclotron, we can see the degrader. The degrader adjusts the proton energy so that it's according to the clinical needs. Carbon wedges are driven into the beamline to reduce the proton speed so that they reach exactly the tumor inside the patient. Reducing the proton energy results in the degrader becoming quite activated, and so we need a heavy lead shielding to protect us from the radiation, even with the accelerator switched off like now. After the degrader, the protons have exactly the right speed, and we can send the beam from here towards the treatment room. This is the end of our visit of the Center for Proton Therapy. Thank you very much for your interest. And if you would like to know more, we are very happy to welcome you for a personal visit here at Paul Scherrer Institute.
Okay, I will resume the sharing quickly. Just give me a second. All right. So I hope you liked the video. It is available on YouTube. So if you want to look at it again, or if you want to share it with your colleagues, you can just access this link and you can watch the video again. And this already brings me to the end of what I had prepared about proton therapy for you today. I would like to finish with this picture of our team. This is an effort which requires many different people with many different skills. First of all, of course, the medical doctors. You recognize them here on in the white coats. They define the treatment. They tell us which regions to irradiate, which regions not to irradiate at all. This prescription then goes to the medical physicists. These are people that have studied physics, but then done some additional education about dosimetry, imaging. They transform this medical prescription into machine descriptions, move the proton beam with the magnets like this, change the proton energy like this, turn the gantry in these different angles. And in order to realize all this, you need the normal physicists that have all these crazy ideas about the scanning, that know how to make cyclotrons, that know how to build beamlines, that know how to optimize magnets. And for the actual treatment, you need the radiation technologists. These are the people that in a hospital take X-ray images, for example. Those are the persons that really do the treatment. There is not a medical doctor or a physicist sitting in a control room, but it's a radiation technologist that does this. And so all these people working together for one common goal, which is for the benefit of our patients. And working in such a team is really a very big satisfaction. And this is why I would like to end my talk with this photo. So thank you very much for your attention. And I'm happy to take any questions that you may have.
Okay, so now we have the interesting part of the session. Now we have a question answer session. So if any of the participants, if you have any questions, you can put in the chat box. Okay, we have got a question. Okay, the question is from Alina Joby. So question is, how does the cost varies between conventional radiation therapy and proton therapy?
Yeah, that's a very valid question. In the very first slides, I showed you how big our machines are, and of course they are expensive. They are significantly more expensive than photon machines, but of course you can share the investment over a large number of patients. So in the end, the cost of proton therapy is about a factor of 2 over conventional radiotherapy. And as I said, we don't say that you need to treat all kinds of cancers with protons, but you need to identify those cases where protons have a clear advantage. That's where this geometrical precision is required. And these are the cases where this factor 2 of costs is justified. To give an absolute number of the treatment costs is a little bit difficult because it's very different in different countries. In my country, conventional radiotherapy costs about $15K US, and a proton therapy costs about $30K US. So this is a factor of 2. But in the US, which is a completely different healthcare system, these numbers are a factor of 10 higher. And I would expect in India they would be a little bit lower, but this is the order of magnitude that you have to pay. So it's in the same order of magnitude that a complicated surgery of a brain tumor also would cost, where the patient stays for some time in a hospital. So it's not only, proton therapy does not only have advantages from the medical point of view, it's not only feasible from the technical point of view, but it is also, it can be, you can defend it in terms of economy. And this is nowadays a very important factor, of course.
Okay, thank you, sir, for that answer. And we have one more question from Joel Rose. So question is, are there any side effects from proton therapy treatment?
Yes. Any radiation therapy treatment, photons or protons, can have side effects, but these side effects are usually not very dramatic. You get skin reddening where the radiation penetrates the skin, so it's like a sunburn. Where the radiation goes through the skin, the hair falls out, but after the treatment, usually the hair grows back, so it's not a very big problem. And it's the same with what you get also in conventional radiotherapy.
Okay, sir. Another question from Krista Vakish. How long do proton therapy treatment last?
Yeah, that's good. I should have told you. I think I never mentioned it in my talk. You don't give all the dose in one shot. You distribute the dose over some time. That's the same like what you do with medications. You don't take the whole box of drugs on one day, but you take one pill every day over a certain period of time. The biological effectiveness is better. So radiation therapy typically is extended over 30 treatment days. So if you have 5 days per treatment a week, when you don't treat on weekends, this means 6 weeks of treatments where each day you give a small part of the dose. So this is exactly the same also in conventional radiotherapy and in proton therapy.
Okay, so next question is from Samyukta. Okay, can we do proton therapy with the combination of aluminum, I guess it's
artificial intelligence, I guess. No?
Oh,
artificial
sorry,
intelligence.
Okay, artificial intelligence, like involving robots for doing treatments, as radiation causes side effects for humans.
So I think there are two parts of these questions. One is, can we send in robots because the robots have no problem with radiation effects? This, of course, something we don't use robots to manipulate our patients. We do this with people, but then the people go outside of the treatment room and then we switch on the proton beam. But AI is an excellent keyword here. Artificial intelligence can, of course, improve the preparation and the execution of the treatments. And we have a number of researchers and PhD students that are exactly working on how to use artificial intelligence in the preparation of the treatment, to identify the regions that have to be treated, and to understand the anatomy. That's one possibility. And then this has to do with the previous question. You don't give the treatment in one day, but you do it over 6 weeks. And during the 6 weeks, the patient may change a little bit. Maybe the patient is not positioned every day exactly in the same way. Maybe during the treatment, the tumor starts to shrink and you need to adapt it. Maybe the patient changes weight during the treatment. It can happen over 6 weeks. So you need to adapt day by day to the changing situation. And this is where we are looking if AI can help us to improve and to automatize the adaptations that have to be done on a day-by-day basis. So very good question.
Okay. Next question is from Nikhil. Okay. Is there any available evidence regarding the use of proton therapy in muscle injury recovery in vivo?
Oh, wow. I think I'm not competent to answer this question. This is really a question that has more to do with biology and medicine. And I don't know the answer there, sorry.
Okay. So I think that's the end to our question and answer session also. So thank you so much, sir, for this wonderful and engaging session. And
Okay,
thank
Sharon,
you.
Sharon, just a second. I have a few more slides to make some publicity for our activities in NPSS, and I would like to share them with you. It will be very quick, but I will go back to, can you bring back my screen? Yes, thank you very much. As you have heard in the introduction, I'm active in the NPSS Society of IEEE, and we're doing there a lot of activities. And one thing where I have been involved now for a couple of years is what we call instrumentation schools. Instrumentation school is the idea to offer a program of typically 1 week where colleagues of mine and myself, we come to a place and give lectures to students. And not only lectures, we also bring some part of equipment, detectors, electronics, Raspberry Pi computers, whatever, and do some hands-on experiments with the students. We have done this already since some years, and as you see, in different places in Southeast Asia, in Brazil and in Africa. Unfortunately, since last year, these events have to be virtual, but we hope, of course, that soon we will be able to come back to do such schools in person. And I have a few photos from a school. This is here in Vietnam in 2019, students listening to a lecture. After the school, we give a certificate to the students. This is in Malaysia, Kuala Lumpur, also in 2019, with hands-on experiments measuring on the lower right, time of flight experiment. On the upper left, it's a demo experiment showing how the imaging of positron emission tomography works, a very important medical imaging modality. So I want to make some publicity for these schools because when the world is becoming normal again, we are always looking for places where we can do this. And if you in Kodakara would be interested to host such a school, then get in touch with us. And we are very happy to organize this and to bring some lecturers that can perform these experiments and do some teaching there. This can be funded by IEEE. So that's one possibility we might talk about and think about it in the future. And I have one more publicity for another event where I am involved. This is a conference that we are organizing from my technical committee within NPSS. It's the real-time conference. This is a conference that has to do with also with instrumentation, with detectors, but with the use of electronics and with the use of software in physics application, in high energy physics, in plasma physics, in medical application, in space flight. We realized that many people are using the same kind of technology, and these are the people that we bring to this conference. Sorry. The next conference is scheduled for next year, August. You see the date here on the upper left. We hope to do it as an in-person event. If some of you is interested in joining these events, we have the possibility to give some grants to students that would like to attend this conference, helping to cover for travel expenses and helping to cover for the stay there. What is very likely is that this conference will also have a hybrid component. So if you are not able to travel there, it will be possible to attend the conference in a video stream like we are doing this now, and to give contributions remotely to this conference. When you present in this conference, it's you are entitled to make a publication in our peer-reviewed journal, the Transactions of Nuclear Sciences, in a special issue that is dedicated to each of this conference. So the website is there. It contains some basic information, but by later this year, maybe October, there will be really much more detailed information, and we will start collecting substracts. So thank you. This was just some quick publicity for activities of IEEE where I'm involved, and I wanted to draw the attention to this. So thanks a lot, Sharon.
Okay, sir. So I think that's the end of our session. So now I would like to thank you, sir, for your valuable time that you spent with us, and also thanks to all the dear participants who came for the session and for supporting us. So this was indeed a very interesting and engaging session. So we're hoping the same the support throughout, and thank you so much.
Okay.
Okay, so now to the participants, they have put a feedback form in the chat section, so please do fill it up, and the time limit is 10 minutes, so make it fast. Thank you so much.